morning, and thank you so much for coming to our UCCCN meeting. So normally Mindy is hosting this meeting, but she's in Pittsburgh. She's actually joining us online with Gina, and we think I'm going to talk a little bit in a second over here. But I would like to start with introduction. So my name is Gabi Baragoshi. I'm one of the QI coaches from UCCCCN. And the topic today is asthma, which is one of my favorite topics anyway. So I like talking about asthma and quality improvement. So if anybody has questions regarding a quality improvement project in asthma, please either see me or Kim. He's also one of the asthma QI coaches. And then I go to you. Kelly, please introduce yourself.
Okay. I am Kelly Baxter. I work with the Utah Department of Health Asthma Program. Kim Bloom from UPIC.
Dawn Dudley from UPIC.
Thanks
so much for coming today.
I work with Jan.
Can you guys speak up a little bit so we can hear you up here too? Thank you.
Rachel Louder.
Thanks, Rachel.
Claudia Bruno.
Yes.
Mike Johnson, the physician, University Department.
And also asthma champion. Thank you.
Colin Kingsbury from Children's Social Health.
Uh-huh.
I'm Gail Johnson. I work in the Life Health and
Good, great, thank you.
Maria Castro, I'm the coordinator with the University of Clinic.
Okay, and then who's online?
This is Mindy. I'm here from Pittsburgh.
Thank you for joining us, Mindy. Okay, then who else is online?
There's Tony Estrada.
Tony, do you want to introduce yourself?
He might not have a
microphone, yeah. And then Jan Walker from Memorial. Okay. Great. Thank you so much. Okay, so here's our agenda for today. So we already did the introduction. Then we're going to do some brainstorming around some cases. If you have some cases you would like to discuss here, please think about it, and in a few minutes you can speak up. And then, as I mentioned, our focus on our meeting today is asthma, and we are really very happy that we have Kelly here from the health department. We have Dr. Johnson here from Primary Children's ER, and then we have Betty Sue, either the manager of the school nurses or school nurse consultant. All right. And all three of them, they're going to have a short presentation, and I will also be more than happy to answer questions for you. And then we have a short wrap-up. Okay? So, anybody has any cases they would like to discuss here? Any cases that you, as a care coordinator or care manager, have difficulty with, you run into barriers you want to address maybe, or you are care coordinator at the community health clinic, you run into some problems?
Yeah, just recently, we're working with a patient that it's a sick mom that just had a twin boy, very low income. They do have Medicaid, and we were just working on trying to find them a crib for the baby. So mom unfortunately decided to purchase a crib, and they're sleeping in the bed with the parents, which is a safety issue. I've been trying to find her crib. I checked crib stores, but I do crib for safety and liability issue. So other than the Lila Rose Foundation, I don't know if anybody knows of any other foundations that will provide funding for the family to purchase a crib?
So does that mean financial assistance?
Correct. Basically, she needs the money to purchase a crib. We did find out the DI store. So and we sent mom over there, and she was told, yeah, we'll give you the crib to bring $500.
Oh, yeah, so is there a DI?
Right, the DI. And so, I mean, obviously, the report for this mom does not have the money to buy the
Other places have vouchers for DI, but I don't know if it's for the youth.
I think it's for the youth. Right, so the new, like, as far as I know, the mattresses, and all that, the furniture,
I'm not about thinking into if there's a church that they belong to, they can discuss that with the church leader, and then that's what
yeah, I checked with mom, she does not.
The church,
Yeah.
The only other one I can do, and maybe you guys can help with the name. There's a place that'll help, like if you have a bill that you have to pay and you're not going to be able to pay it, they will help with the funds, but it's usually a longer waiting list. I remember the name of it. But I was surprised there is such a thing.
where are you located?
In Salt Lake.
In downtown area or?
I've only called them those things, but I can't remember the name of it. But they would give cash before, like a one-time cash before.
And the cash be able to afford any type of purchase
So
or?
in this case, it seems like a reasonable argument.
Yeah, that would be great.
Mm-hmm.
If you can't, if they all else, you could call Linus House and ask Amber Matthews. She might. I know. I'll try to text her real quick too.
You know, the Utah resource, pregnancy resource center, I know they provide clothes and formula and everything else. I don't know about Chris, but if you were to try. Yeah, we tried out. So I tried how many places, and most places don't do these car seats or Chris because of the liability. Yeah, I tried everywhere, and I submitted a request for an application to the Laser Road Foundation, so we really did it.
This is just a weird comment, but I think our culture, we're into cribs. And in a lot of places in the world, people do alternative sleeping areas, like floors or things. So,
Just a mattress on the floor.
yeah, it doesn't have to be a crib. Like, I think that's kind of a hang up in the States.
No, but I agree. In this case, this is one of our providers is the one. President, we have to get your kids because they're sleeping with mom and dad.
Right, but yeah.
And so, tricky.
I think on KSL sometimes people are giving away free. Yeah.
And there's also there's an organization that you can go and they might give you a voucher, or at least they have maybe some resources for you too. I know the address, but I don't know the name. But I will definitely resource and think about that and then get back to you. That would be good. Okay, Maria. Yeah. For newcomers, the case we're discussing is that she has a mom who's looking for a crib and needs some financial assistance to get a crib. She absolutely cannot afford one. And I believe the DI is asking for $500.
Yeah, because it's too big, so she has twin boys.
Twin boys, so two cribs, $500. And of course, out of the question. Yeah, so if you have any ideas.
There's one on KSL.
No.
It looks like it.
I do.
Yeah.
All right. First crib down, one more to go.
You start with one and then
Yeah, no, that was very fine. Yeah, we should all do the same. Here's I'm Googling who is low income patients health related Christian parents. And it's EPAOA.org.
EPAOA.
Parents Expecting Parents Alliance of America.
Yeah, the resources of what is advice and they can your friends. So that might be. Great. All right. Awesome. Thank you so much. No problem. Anybody else who would like to address some barriers they're running into while taking care of families or children and children? Everything is perfect. That's great. I'm more like 40. Thank you. They've been just right one page just talking about it. And the majority is financial assistance, right? And if you know, it's a problem, like no health insurance or no money for medications or yeah.
She texted that, and she thought it might be CAP to program or across the river.
That's the one. Cross with Irvington. That's the one. They have helped me in the past on some of their patients. Yeah. And CAP, because it's C&E.
Yes.
Kim?
Mindy typed in that we should ask if anyone has any motivational interviewing or QI wins to report.
Okay, so he will be a community action sponsorship. So it might be, might be actually just resource. Okay. Yeah, motivation interview. Anybody can report back on if they used motivation interview recently and how it went. It's an art to do motivation interview. Very, it's a lot of practice. Dr. John is here. He's looking at you.
I don't know, maybe I do, I don't even know it. I hear it, but I've never really, sat down
And then
actually
research it, and I think the biggest thing is to have open-ended questions. Sorry for the patient. And the other question we have
QI wins.
Anybody think QI cultures in their practices or organizations? You might do it, you just don't know it, maybe. Yes, I could just say that when we started working on education and improvement, about money. So, I usually put out surveys to teachers and I think I have like 17 about what their current practices or money. And yeah, I think so what I've done is put together, we haven't met yet, but put together a group of interested parties like environmental people, water people, and doctors, stuff like that, to try and figure out if we have a problem during this conference. CDC changed their guidelines about 5 to 6 years ago, and because standards were still behind the times. So that I'm hoping will be like a quality improvement of practices, not maybe
getting a better questionnaire for our state and getting the state to change the guidelines to what the standards of care.
What is the AAP guidelines for lead screening?
All kids should be screened. Usually
So all kids?
yeah.
What the practice is only kids with suspicious environment, in suspicious environment get screened?
There. And the only place that I can find it routinely screening, like, Head Start and H3 and actually life. So I think the bottom line is we don't have very good data because standards used to be greater than 10, and maybe a lot of people didn't get that, but now that the standards are any level kind of bad, and anything over 5 is considered unacceptable.
Unacceptable.
We need to gather more data and do that. I'm trying to do it through WIC because they screen for hemoglobin at 12, 24 months, but I think at this point they're not the time to do that. So I think educate more and get more data. Online data is mostly important to say. A lot of people don't know that. Everything, every blood level is done. It's supposed to be reported to the state. Like in 2014 or so,
It's very low.
so
Yeah.
we might not have a problem, but we don't know.
Yeah, that's a good question. Do we have a problem in older houses?
We were researching that because one of our doctors found that Medicaid guidelines are 12 and 24 months. Yeah. And so those are federal guidelines. Every Medicaid. Yeah. And we're starting to change our process, but then ran into kind of a brick wall as far as who wants to do this at the state. Yeah. I mean, there was just kind of, okay, I think, like, once you do it, I don't want to be angry, and so, you know, and I want us to have a better questionnaire, like we talked about questionnaire. Questionnaires aren't good, like the national stuff here, they have sort of stuff, you know, and it's like teenagers, and we just don't think we're asking the right questions.
The right questions?
They don't know when they're they don't know what to say. They don't know a lot of that stuff.
You would think that parents are more aware now of lead poisoning after St. Michigan, right? That they would ask a pediatrician.
Our state, once they look at our website, it's like not healthy because
Yeah. In your practice, Maria, do you?
it's reading that we do with the 24. I don't know if it's reported. I know that we get the results for all the kids that are screened. I don't know if the results been gold anywhere. Yeah.
At least get a baseline, get the data. That would be.
Yeah, there was
That's the heart of a life project, right?
Newborn screening, you know, those screening. What's the doctors, like, you get these levels, like, one interpret screening, which may not be as accurate as either, but certainly more convenient, and I would say that's and what if you get these screening scores? Doctors don't really have guidelines to give parents to say, we don't need an intervention. I mean, we need to give parents patients, we need, you know, saying, let's check you in a couple months or whatever, you know, we try to come up with so that the practitioners have guidelines, you know.
Well, keep us posted on that one.
I'm sure you want to be involved.
Are you working with a specific person at the health department?
No, I came up to somebody who was doing it. So, I got some commissioners maybe.
Oh, we have to help you. I don't know if Kelly knows anybody or.
Oh, I want epidemiology that I'm working with. Which is like a big thing, and I think we'll be working, I think it'll probably be deputy director, you know, decision on what it takes to change guidelines and stuff. So they will be coverage for environment and the water people and the lead-based change people and state health Utah.
Mm-hmm.
I can't remember everybody, but there's with Start, a lot of stuff.
You know, Greg works. My neighbor, I think he rents a lot of these.
Okay. Yeah.
I think you've seen that.
Good. Next one is almost very good, right? So I like that. Connection somebody to you. All right. Anybody else before we move on to our next topic would like to share something? Brag about something, what you do in their practice? Always good. Yes, thank you. Yeah.
We, the school nurses in the state, have been collecting data for years, but nobody has done anything with a lot of it. Last year, I just started a position to take with it. We got the data collected from our school nurses, put it into the report, which now they can see why I'm collecting the data. So I think that hopefully they'll be more willing to invest something that it is. So the number of kids with each chronic, asthma, allergies, diabetes, those kinds of things, those two healthcare plans.
Behavioral health issues too, or
Not so much
not
yet,
so much?
but
Okay.
we're starting
Good.
small, and then between data that CDC is asking for and the National Association of School Nurses. We're starting out, and then
Very good. So you're in this position since April.
yeah,
Already making this?
yeah,
Good.
I've been very good for 16 years, but so I'm on a data, so I like collecting numbers. But we had never shown them what was
Right, right, and that's very important to actually show them why you collect something. Otherwise, they don't see a reason
There's
behind
a
it.
buy-in from them.
Correct. Good. I hope you're also going to see some more of the data.
Yeah.
Really good. Okay. Good job.
Yes, please. So I've been working for a long time. When I first started as a pediatric care manager, benefits there was these big need that I see that everybody needed, and that was a limited resource. So I've been working with people over the last year and a half, and we're still working with Gina, Terry Carter from the independent waiver, to build some community resources for volunteer respite care. So it's been back and forth with different organizations, but we think that this year we probably really will be able to build something in the community. Maybe with the Utah Caregiver Support Network. So we think that, and I was able to go to the National Respite Conference in Colorado this year last month, and anyway, we think we're getting the community partners.
Very good. Very good.
So,
Yeah.
so anyone's really interested in helping support us for children, our focus is children with special
Special needs, of course, yeah.
The Utah Coalition for Caregiver Support, they are more focused, or have been historically more focused on elder care, but they want to support the lifetime.
Very good. Yes, very good. Well, I guess we got to give a hand to all of Eddie Sue and everybody who's doing something for the community. Very good. Like that. All right. Well, our next agenda is the asthma topic, and so we're having Kelly Baxter from the health department, and then Dr. Johnson from the primary children's ER, and then Eddie Sue, the school nurses. They're going to present some slides, but I would like to encourage them to actually interact with each other. So if Kelly presents and Dr. Johnson, Dr. Sue has something to add to Kelly's presentation, please speak up, and vice versa too. Okay? All right, Kelly, do you want to come up here? Yeah.
Okay, so I'm going to pass this around. This is the curriculum that you offered that one that I'll mention, and then the in-home assessments that we do in the students, so you can actually see it, because there was no way to actually include it on my slide.
Go.
All right, so I work with the asthma program, and I am more the coordinator
program than someone who actually goes into the home. So I saw Tiffany Britton's name on one of the tags, so maybe she's been here.
Yes, yes, she has been. We had an asthma presentation last year.
Okay.
In October 2, I think October becomes our asthma month, kind of. And so that's why you see her name up there.
Okay. So Tiffany does the visits in Salt Lake County, and then we have another partner in Utah County, Andrea Jensen, who does the visits. So I know a lot about how we develop and implement the program, but I don't have a lot of first-hand experience in the home, if that makes sense. I've just gone on a few visits, but I could refer you to them if you ever want to discuss with them how things actually go in the home. So a quick background on this. We are funded by CDC, and CDC went a lot to doing work with health systems and quality improvement, which we partner with UCCCN to do QI and clinics around asthma. And then as far as community programs, they went to working with schools where we run Open Airways, which is American Lung Association self-management program for children ages 8 to 11, and to doing home visits. So about a year and a half ago, we started developing this program based on what other states had been doing. We developed the outline of all the visits, the curriculum, and we had a number of great partners that helped us with that, one being Help2U. So they also use this curriculum in some of their home visits that they do. So we began going into homes in January of 2016. We only fund Salt Lake County and Utah County at the current time. So I don't know where everyone's clinic is, but for now, does that cover pretty much anyone here in Utah County?
Yeah, pretty much, yeah. Mm-hmm.
We would like to expand, but it's just an issue of funding. But we have the program ready if we do get the chance to expand to other areas. Our target population is persistent uncontrolled asthma. So when we're doing intakes, we use the asthma control test to determine control, but usually for clinicians, they'll use the NADP guidelines and then decide who's uncontrolled, who's persistent, and then refer them. We take all ages, and the program is free.
So I have some feedback on this program. So I'm working with one of the clinics here at the Rose Park area, the Rapid Clinic, and they have referred patients out to the home program, and the patients and the providers love it. They really love it. It's a great program. No, indeed. I got the feedback just yesterday too, so yeah.
Okay. So this is a brief overview, and then I'm going to go into more detail in the future slides. But once we receive a referral, we do an intake phone call where we ask questions about asthma control and just other data questions to see whether we think they're a good fit for the program, because we really do want to reach those who are already doing all of the things that you would generally think, taking your medications, et cetera, but it's just not working to see then if, well, maybe there's something with the home that we need to fix that can help get their asthma in control. So we'll do an intake, and then if they qualify, they'll go into this 3-visit program. So the first visit is asthma education, which that's the colored pamphlet that's coming around. So it's a flip chart that we'll go through that has a picture on one side for the homeowners to see, and then speaking points on the other side for the health educator that's in the home. We talk about asthma symptoms, triggers, medications, and then we'll do a demonstration and return demonstration of inhaler technique. And visit 2 is a home environment assessment. So it's a pretty thorough walkthrough of the home that looks at all kinds of different things, and then they'll identify triggers and set goals to reduce triggers in the home. And then visit 3 is the shortest visit. It's just follow-up. So we touch on the key points again, like inhaler technique and the difference between the asthma medications and when we need to take them, and seeing how they've done on their goals. And then 2 follow-up calls, which are just for data collection and to answer any questions that the homeowners might have. So visit 1 and 2 we found end up taking about 60 to 90 minutes each, and then visit 3 is usually between 30 and 60 minutes.
And the providers get a detailed report back on those visits. but you know exactly what was covered and what the triggers are, so the provider can adjust the treatment accordingly.
Yes, and we'll work with clinics to customize the feedback form so that whatever the providers want back from us, they can.
And there's an incentive for the participants as well.
There was.
Oh, okay.
But we've had enough participants that it used up the incentive, so we're not marketing.
Still a great program.
Yeah, I need to go with my day. I just did that meeting she did that last week.
Yeah, she has some gift cards left, but as soon as it's 5 per participant, so for each visit and phone call, so she's calculated how many more participants she can have for the incentive. So this is just an example of the curriculum that's being passed around, those little pictures at the top, and then this is the goal sheet at the bottom. So on the left it says what I will do, so they set their own goals, and then steps what I'll do to do this, so including when and how often. So we have our home visitors go to motivational interviewing training, and we really try to make this curriculum applicable to the homeowner. So when we go in, we ask what they're interested in learning about, what they want to focus on, what their priorities are. And that way we're not going in and telling them, oh, you should do X, Y, and Z, when if they have no intention of doing that, then it's not helpful to make recommendations that they're not interested in doing. So we do try to customize the program to them, even though we have that set curriculum that we go through each time. And then this is the home assessment that I passed around as well. So the main areas that we're looking at as far as triggers are dust mite, speeding, mold, pets, and tobacco smoke. So they'll go through and walk through the home room by room looking for things within each of these categories. So any signs of water damage that may indicate over moisture, they'll check the heater to make sure that they're switching out the filter if that needs to be done. They'll discuss the importance of dusting, sweeping, vacuuming, doing dishes in a timely manner, not having leaks in your faucets that might bring in pests into the home. Most people logically aren't just going to get rid of their pet. You know, they have a dog, found a dog, everyone loves a dog. They're not going to say, well, put it up for adoption, time to go to the shelter, that's it. No one's going to do that. Yeah. So instead with pets, we'll talk about things like try to keep them off the bed, make sure that they aren't sleeping in the child's bed with them. One of the stories that I liked from one of our telehealth presentations is we had a pharmacist at the University of Utah that he works in the asthma and birth clinic, and they had this patient wasn't controlled, and finally they found out that they had a pet ferret that always slept like right on his chest at night. And it's like, oh, I'm not going to want the ferret on your chest while you're sleeping. That could help with some of your asthma symptoms. So just talking about things like that some people might think are common sense, not to have the animal in the bed, but that some people don't think about just because they love their cat and they want to. Tobacco smoke will make a referral to the quit line if the parent is interested in quitting. It's definitely not just quick resources. And then at the end of visit 2, they'll fill out another goal sheet where they choose one trigger and choose what they're going to do and how they're going to do it. And part of our referral with the home program is to connect them with resources in the community for potential home remediation. So in Utah County, we'll refer most often to the Housing Authority of Utah County or Habitat for Humanity. And these are some of the things that are offered by those organizations. So the Housing Authority offers low-interest loans for home repairs to qualified homeowners. Qualified is usually an income issue. So if they meet a certain income level, then they can get loans to make repairs in their home. They also offer weatherization and energy prices. So one example is if someone has a furnace, the furnace breaks down, that's their sole source of heat, and they don't have the money to get it repaired, then they could contact the county and try to get funding to either get a loan to be able to afford the repairs, or potentially, I know there are some grants that they can cover it. And with Habitat for Humanity, we actually work with their construction manager and And in Salt Lake County, we refer to the Green and Healthy Homes Initiative. So Green and Healthy Homes is a national organization that has certain locations throughout the U.S. that they also work with. So it's really awesome that Salt Lake is one of the few locations that they're working in. And they work with the same types of programs as Utah County, but they call it grading, where they bring all of the programs offered in the community that work on housing, and then they kind of grade them together into this coalition where you go into the home, and it's not just weatherization that goes in and does weatherization's job, but they go in, they look at the home as a whole, they communicate between organizations and say, okay, what do these homeowners qualify for? What could be done in this home? What should be done? The first thing that they have to do with grant money is getting the home to code, and then after that they can work on some projects that the homeowner wants to have done. So we'll refer families that qualify to them, and then often Tiffany and Salt Lake County will go out with the Green and Healthy Homes construction person to do visits together if they qualify.
So what are the options for apartment buildings?
I don't know all the ins and outs of owner versus renter, but most of the time people have to own their home. Qualify for that. And if you do want those resources, I can get you to the Green and Healthy Homes person. Yeah, because I think we had a family that we referred to as Green and Healthy Homes, and it was a family that was renting, and they identified a trigger which was approach in the apartment. And I think the issue after that was trying to get management to fumigate the apartment. That was our barrier with that happening. So Green and Healthy Homes did a great job. We had parts coming to the house and after that it was a little.
So did they talk to the housing management and
they did. And then we just had the family come back and saying that they were not doing it. They had come to the recommendations of Green and Healthy Homes to fumigate the patient. We're not doing anything about it after that. So they just probably just ended up moving to okay. Yeah, and I think the same problem with multi-unit housing things too, like our tobacco programs that will work with multi-unit housing to try and get it smoke-free. You're really limited by the owners and what they are and aren't willing to do. Yeah, I think that was another one that we should go with a different family. The neighbors were smoking and almost trying to do the rent. So then there was nothing really they could do when they talked to the management. Other than move, which, you know, nobody wants to be told that, well, you're just going to have to move them, but oftentimes that's
not an option, but they don't find anything.
Okay, so since we just started in January, we're in the beginning stages. I don't have a lot of data to share, but we have 60 people that have enrolled, 30 that have completed the 3 visits. Of those that completed, we had 100% that were able to demonstrate correct inhaler technique. The percent of people who had a passing score on our asthma knowledge assessment group was 32 to 68%. And only of participants with uncontrolled asthma at enrollment, we have 48% report controlled asthma based on the ACT test after visit 3, and 37% that reported better adherence to their controlled medication. So they were taking their controlled medication more often than they were when they started the program. We also are collecting self-report data on ED visits, hospitalizations, courses of oral steroids, but that's our 6 and 12 month follow-up, so we don't have any data on that yet. But if we do, we will be sharing it.
So correct inhaler technique sometimes is really a problem. You know, some providers, healthcare providers, they are not even quite clear how to teach the patient. And what Tiffany, who is doing the home visiting program, also does, she goes to the clinics and basically teaches the providers how to teach the patients. She did it in Radcliffe, and they all loved it too. So that's also very positive. That still happens. Yeah. So of the 50 people that
that we've enrolled, these are some of the referral channels that they've come from. Our local health departments work with community organizations and clinics and hospitals to try to get people into the program. So I think that Mike will talk more about how we set up the referral process with memory children, but you can just see some of the other organizations that we've worked with. DUI, American Law, Green and Healthy Homes. We refer to them and they also refer to us, Community Health Energy, Health Energy, Kids on the Move, and in both counties we work with in our family partnership. So I included in the slides, I wasn't sure if people got a copy of the slides.
She will get the copy.
They will?
Yeah.
Okay, so I put in every insignia's phone number just because I thought you wanted to get in contact with them. They're really the best person to contact because they'll get your tax referral sheet and talk about how you want to send the referrals and what type of feedback you want.
Bilingual?
Spanish and English.
Mm-hmm.
Yeah. I did want to mention one thing about capacity. Andrew and Tiffany are the only people running this program, so they always have a second person that goes with them into the home for safety purposes. But it's a two-person show, so right now we have been able to accommodate all the girls that have come in that met program criteria. But in the future, if we did receive so many referrals that we couldn't manage them, we would probably just make the intake requirements a little more strict as far as who qualifies under the persistent uncontrolled asthma. We would probably just make them have like a lower ECT score or something like that. We'll deal with it when it comes, but just wanted to show that we aren't huge and we would love to get bigger, but right now we're small.
So on the same lines, again, with helping you and being part of this, we are happy to take care of our, and they do have to be helping you. We've had sometimes questions, people have called us saying, well, we have Molina, will you still come out? And I'm like, well, not us, but not the health department. But we have had a couple that we've gone out and the family said, oh, we've seen this foot truck before. The health department had gone out like a week before and they just couldn't realize that we were doing the same program. So anyway, so if that's what we use, call us. Okay?
Yeah, and we need to work on that because we asked them during intake who their insurance provider is, and so that helping you, ideally, we shouldn't be going in. So we'll have to work on that on our end.
Communication.
Yeah, exactly.
Maybe a dumb question, but is it for anybody? So meeting the criteria. So insured, uninsured, commercial insurance.
Yep.
Anybody. All ages. Alberta, pediatrics, and grown-ups. Yeah.
It's really just a matter of how in control their asthma is, and that's the main thing.
There's the back of the sheet usually. The referral.
No, the fax is fine. Honestly, all we need is a name and phone number, and to know that the patient agrees for us to call, because from there we'll do our eligibility. Any other questions? Let's see. And then I'm sure people here probably already know about all of this, but I just wanted to mention a couple of the resources that we will refer into, and in case it's helpful at all. So if we have anybody who doesn't have insurance, we'll refer to Take Care UCCCCN. So it's a network of certified enrollment experts that help people identify if they're eligible for health insurance under ACA and what their options are. And the money for Take Care UCCCCN is provided through a CMS grant to Utah Health Policy Project. So if you go to their website in this bottom left corner, you can just type in the zip code, and then it will pull up any organizations with a certified enrollment expert. So if they don't have insurance, we'll find someone to refer them to see if they might be eligible. And then for prescription assistance, we will usually help them figure out whether they'll qualify. So one really great website that we'll use for this is medimeds.org, and we'll find out what medication they're taking, and then for brand name drugs, the pharmaceutical companies have to offer some type of charity arm for for the medications. So each pharmaceutical company has different requirements, but as I looked at them, the three main things that stuck out are you have to be a U.S. citizen, you can't have prescription drug coverage, and there's some income requirement, which is usually between 200 and 250% of federal poverty level. So the person will have to get the paperwork, fill out their end of it, take it to the physician, and then the physician signs. We recommend that they write like a 90-day prescription with refills so that then they can have a 12-month prescription. The turnaround time is usually 3 to 4 weeks to get that medication. So for some patients, they'll have to have one prescription to take to the pharmacy that day to start taking things for a month, and then after that they can have the prescription medication for a year, and then they just have to go through the same process of filling out the paperwork to their physician and sending it in. And some of the medications will have to come to the provider's office, where sometimes they can be now right to the patient's home. It's just a hands-on program. And one thing I want to mention in addition to this is there are some copay assistance programs for people who do have insurance but can't afford the copays. And every Benson in Utah County, she has asthma, her kids had asthma, and one of her children was on Bill-Lair shots, which were insanely expensive. So she went through the whole process of the copay assistance program, so she knows that really well on how to get people connected with that. And then this last resource is livingwell.utah.gov. And I just wanted to mention it in case we've had any family practice offices that were here, because it's really, most of the programs officers are here for adults because it's self-management of chronic conditions. But all of the programs that we offer at the Bureau at the Health Department, we put onto one web page where you can learn about them and register or refer a patient. So this is an example of some of the programs that we offer for arthritis, diabetes, cancer, heart disease. And I pulled up just screenshots of the website. So if you go to overview of programs, that will pull up by categories. So, oh, good, I do have it on the next slide. So you can see all the programs we offer by arthritis, asthma, cancer, diabetes or prediabetes, falls and injury prevention, and tobacco. So when you click on that, it'll pull down each of the classes that we offer, and then over on the left side, it has the fax referral. One thing with the fax referral is we have to have a clinic agreement on file. So before you can send referrals, someone at the clinic, usually a clinic manager, has to sign it to say that they're getting it released from the patient to send the contact information to us. Because we are not, at least our specific part of the Department of Health, we don't store the data with compliance measures. So we need to know that there was a release to send it to fax it to our fax machine. And then on the left is, if you click on the Find a Program, it'll pull up there where you can put in the zip code, the class, and then search programs, and then you can register right from that screen. That's all I have.
Great. We might have questions maybe asked. Oh, sorry.
Kelly, is all this available through 211? We talked 211.
I'm trying to remember if these programs, if all of them are or not. I'm not sure. I would have to ask.
That would be really nice because, you know, that resource is really coming more and more and more, and people are trying to tap into it. And if people are available out there through the health department, that would be really cool.
Right.
Yeah. I don't know. It's pretty easy to add programs to their listing.
Okay. And I'll bring that up. I know that we have talked with them, but as far as all the other programs in the Bureau that have their classes on this website, I'm not sure. So I will ask.
Good question.
Do they enroll that you know of from, or do they just tell them about the classes and give them information?
You can even go in and add information, and then they'll just post it. And then they keep it updated, too, which is really helpful. So if I hand a paper list of something that's outdated in 2 months, where they'll just keep it updated. So
that would be really helpful. Okay. Great, thanks. Any other questions? Our next speaker is Dr. Johnson, and he's old school. He has his life.
This is a break. Get a little 15-minute break. So it's really kind of a treat to come and meet a group of people that come from such diverse areas, but we're all working on something very similar. And I think that's kind of the theme of what I wanted to talk about, because I work in the ER, and we are notorious for being cliquey and keeping to ourselves and doing our thing and then kicking kids out back into the community, hoping that they don't come back again and that they have what they need. But we're often doing that at 3 a.m. and we don't have the ability really to know and have a full idea of what's happening with these kids outside our doors. Parents are bringing them in because they need something right then and right there, and we can provide that for them. But we always have this nagging feeling in the back of our minds that we're not doing what we need to for these kids. Ultimately we spend, a couple hours with them out of, their entire life. We know that we have an impact that matters for those 2 hours, but we don't have really the opportunity to have as big an impact on their lives as you do in their clinics, in their homes. Even their insurance has a bigger impact than what we can do in a few short hours. And I'm here, I have an interest in asthma, but that interest for me goes beyond just what we can do in the ER for those kids, out to how we can help support what happens other places, and also not just try and support, but also pull on the resources that are in other places so that we can provide those for these kids. So just to give some perspective, we at Primary Children's, we see about 1,000 visits from kids with asthma every year, and probably 700 or 800 of those kids are kids who really need treatment. They need pretty intense treatment right from the moment they walk in the door. And historically, we've hospitalized about half of those kids that walk in the door. So, in general, they're sick kids who, even when we treat them in the ER, we can't turn things around in a couple hours, and they need to stay for a while. That's in the perspective of the state. So we have about 1,000 asthma visits, or about 2,500 asthma visits that happen in ERs across the state. So we see maybe about 40% of the asthma visits. Of those 2,500 visits, 80% of those happen at intermountain facilities, and about 20% of them, so about 400 of them, happen at non-intermountain emergency departments. And not just ER visits, that doesn't count urgent cares or acute visits that happen at clinics, and there are a lot of those. So when we sat down and thought about how we were delivering asthma care about a year ago, we realized we have some room to improve. And so we started to work on how quickly we were recognizing kids as having asthma and needing treatment and getting that treatment started quickly. And we went through a big quality improvement process to help reduce the time that it took us to deliver treatment. And that ultimately was, the solution for that was for us to take a lot of the decision-making ability, not ability, but the decision-making responsibility out of the hands of our physicians and putting it in the hands of the nurses who were triaging these patients and were the first contact for these patients. And so we basically turned our whole process upside down and made it something that our nurses could do from almost start to finish. And we were able to really improve how quickly we delivered medications. And in the process, we were able to eliminate about a third of the hospitalizations that happen after kids come to ED. So rather than 500 hospitalizations, now we have about 250 or about 300 hospitalizations a year. So beginning with that, all the physicians that I was talking to as we were developing this and getting it in place were always asking, well, what are we going to do for these kids when they go home? Because we do this, we don't think about starting controllers, because often we don't have a very good picture of what's happening with them in their home, a good picture of how many times they stand in to see, see someone in the clinic or whether to have a really solid primary care doc who manages them closely. We just don't, that to confidently make a decision about that takes, I think, a fair amount of information and understanding of the family that we just don't get when they're in the ER. So we focused on how we deliver treatment, which I think is common. I mean, that's what we all do in our own little sphere. We focus on getting what we do right, and what happens after somebody leaves our doors is often secondary. We hardly ever get to the point where we're satisfied with what we do, that we can actually start to work on what they might need outside of our own sphere. But we were going through this process. We were shifting the whole way we delivered care so that we were doing what the patient needed, not what was good for the doctor's ego or what was good for our timing. And that started to bring up these ideas that, well, what's good for these patients probably means we need to start improving what we do for them once they get home. And I was sitting in a meeting, and we had their little plug about the home visiting program. And they said, well, anybody who has a hospitalization or has an ER visit probably would qualify for the program. I thought, oh, well, I have 1,000 kids to add to that. And so we went down to the health department. We sat down, and I had 1,000 kids every year that would qualify for well, most of them would fall into the Salt Lake County program. So for one person to visit every year, which is only 3 people a day, 7 days a week. So, and well, wait, there's 3 visits, times 3 visits, so that's only 9 visits a day. So there's a need out there that we realized we had the opportunity. We were a kind of funnel where these kids showed up unrecognized by us that they needed more care, but we were a consistent point of contact for them because we caught them when they were really sick. So looking through those kids, about 1,000 kids. Like I said, about a third of those kids end up being hospitalized. So we have about 300 hospitalizations a year. We have about a group of maybe about 50 kids that come more than 2 times to each year. And maybe about 100 kids that come, maybe fewer than 100 or so, that come more than once. So we started to look at that group as being kids that would really need the program. And for us, that's just kind of a really rough, they came to the ER twice. We think they're in need of something. That's not even looking at these more kind of refined, closer measures like their asthma control scores, which are really valuable. So we set up a process, and we totally have our improvement in our ER was partly supported through pediatric specialty services, which is something I don't know, you may or may not have heard of this, but it's a joint effort by the University of Utah and Intermountain Healthcare to help improve the way that we pay for healthcare. And it's focused on children, the pediatric specialty services. So what they are basically doing is trying to work out payment agreements that rather than paying the hospital for all the stuff it does, which is kind of the traditional way that we pay for patients' care, to say, well, primary children, do you provide care for 10,000 children? That should cost about $5 million, whatever the amount is, a set amount every year, and provide that care with that amount of money, meet quality markers, and whatever, if we can reduce utilization and improve outcomes, that's a plus for the hospital. It should be a plus for the patient, and it should be a plus for the insurer too, and then that can be passed on to the patient in lower rates. You can imagine there's a lot going on there to try and make that happen, both like working out the crazy details of what that means from a payment point of view, but also how do we improve care in a way that makes it less expensive to provide care and patients get more out of it and they do better in their health outcomes. So we have to reduce hospitalizations. When we started to get this idea that there were these programs out there that would be absolute bear to try and create ourselves. If we tried to create a home visiting program, there's a lot of detail that goes on into it. You know, some really nicely done details as far as the education that's done, the expertise that goes into doing these visits, and just the management of keeping up with these families. And with these programs in place, we wanted to take advantage of those, really, and get patients to these programs because we knew that they would benefit from them. So PSS also, PSS has a special interest in select health because that's kind of their core population group that they are starting with to try and manage. And so we took that list, we figured out who had come multiple times, who'd been hospitalized, kind of made a prioritized list, and we started sending that over to the Salt Lake and Utah County Health Department about a month ago? It's been about a month? Yeah. And so what we do is right now we're just working off this backlog list of kids that have come in the past. Our case managers in the primary children will have that list in front of them. They'll call the families, just ask their permission to send their information along to the health department. And then we'll take whoever has accepted that invitation onto the health department and contact them. And we've had, you know, we're working through like who's been enrolled, but I think we've had about 10 patients who we've actually contacted. They've actually enrolled in the program, and we're just trying to, you know, hold back this dam that's holding back 1,000 kids from hitting the health department all at once. And we hope that that will continue. And once we get through this kind of backlog of kids, then as we go forward, if a kid comes into the ER, we'll recognize that then and we're trying to keep this out of the hands of our physicians and nurses. Because I know what happens when we have a really good program that depends on a physician who might or might not know about the program, to recognize that a kid might or might not qualify for it at 3 a.m. to send it back to the health department, which, at least in our environment, that would never really happen. Because it's just, you know, it's a detail that is completely outside of our providers' thought processes when they're trying to manage a big ER and trying to get what's needed for these kids. So our hope is going forward that when a kid comes into the ER, within a couple of days, our case manager will give them a call. They will refer them on to the health department. The health department will continue to get funding and money for even more people to be able to go out and do home visits. But ultimately, I hope that by partnering this way, we can help provide some of the outcomes that happen with these patients, and also be able to combine what information we know about them with what the health department knows so that we can better demonstrate the value that this has. Because if, let's say, we can visit 10 families and we can prevent a hospitalization, well, that was worth $4,000 right there. That was worth about $3,000 per day of hospital. So if we can demonstrate the value of this, I think HealthyU already knows the value of this, and they're putting this into their insurance product already, that more insurers and providers will recognize that that's worth every penny because it's good for the families, it's good for the amount of resources we expend on these families, trying to help protect them and care for them. And it's good overall because those are resources that we don't have to expend, that we can use other places. And it helps us overall have systems that are integrated really well so that people don't fall through the cracks and miss out on opportunities to have something really valuable for them.
Just along those lines, that's something with all the data we're collecting, we're trying to do is making a case for the program so that then we can approach other payers and say, here's the program, it's ready to go, these are the outcomes, and lots of times they'll already have something in place like HealthyU did where they were going into homes, and so they'll pick up the curriculum and do this asthma-specific piece with those patients. So hopefully then that would increase our capacity and it would be much more sustainable than just having Andrea do it.
Yeah.
So.
Well, and part of this too, we want to, even if, let's say, every insurer picks this up, we want to be, I don't know, there's still a value there. Like with HealthyU right now, I can recognize that a kid has walked into the ER and it was an asthma visit, and this is the second visit the day after they've come to the ER. where it's probably 6 weeks. Well, it's 6 weeks later before the actual coding and billing is wrapped up and things end up going over to the insurers. You've got a 2-month lag at least before you could contact a family. We already know, like right now we're working on this backlog list of kids that came to the ER months ago. You know, if the kid's doing fine, they don't feel like parents don't feel like doing anything different about their asthma. Where in the moment, if I'm talking to a family the day after they were in the emergency department about improving their health, we've got a much bigger opportunity to get in and make a difference with their care. And that's like all of us. You know, I am totally motivated to make sure I know where my dental floss is the day after I go to the dentist. But you know, after that, 2 months later, I still floss, but it's just not as big a priority. So that's basically what we've done right now. And you know, I view this as an opportunity to improve collaboration wherever we can. We know that from an emergency department perspective, clinics get very little information from us, and we know very little about what happens in the clinic. And I don't know, you know, that's a fault of, you know, our system that doesn't allow us to do that communication very well. But I think hopefully this is one opportunity where we can improve that in a way that helps provide some benefits for our patients.
If you have children and you recognize they don't have a medical home, they don't have a PCP, do you help them to find somebody, or do you just say, oh, that's luck?
Well, if we can. So we do have case managers who work in the ED, and they can help to do that. There's often if somebody does not have a primary care provider, it's easy for us to refer them to Clinic 6, which is the University Pediatric Clinic. And that's generally what we'll do, because we know that they can get an appointment really easily. That'll be someone that at least they can see, they can establish with at first, and then if they need to move from there. That's generally our first point of contact to refer somebody.
Asthma action plans. Do you give them after every ER asthma visit?
Nope, we don't.
So
because we have no idea what their current asthma action plan is. You know, it's a little hard to give the perspective of what it feels like in the ER when it's 9:30 in the morning, and you know we've all, you know, just had I'm sure you all had a great night's sleep and you're well rested and wide awake. For a parent, sometimes they remember that they're taking the controller, sometimes they don't. Sometimes they remember the dose, but generally they don't have it with them. They know they're on Flovent. They can't remember how many puffs each day or which dose of Flovent. And so to try and recreate an asthma action plan for somebody during an ER visit, you know, which is going to last 2, maybe 3 hours at most, and we're actively trying to keep the child from, you know, fail with the breathing, is really challenging. So I don't know, in my ideal world, we have an asthma action plan that everybody could access in some way. You know, that I could log online and say, I know this child is in my ER, what is their current asthma action plan, and when it's updated? And then I can contribute to it actually in a meaningful way. Because I know there are times in the middle of the night that I'm going to, in fact, just yesterday I had a kid who was hospital caring for the child that scored really poorly on their asthma control test because they had symptoms. They needed their albuterol twice a week. They had symptoms almost every day. And I said, okay, great. Have you been on a controller? No, I haven't been on a controller. Let's get you started on a controller. I prescribed her an appropriate controller. I called her doc's office to make sure that they knew I was starting a controller. And then as I was looking for their record, she had been prescribed a controller in November. And, you know, I don't know what happened. You know, I didn't realize that until I already set this all up and then sent it home. You know, Mom didn't realize that either, you know, thinking back to November. And that's just life as a human being, that we forget these things.
I had several parents who said, well, when I was at the doctor, they didn't give it to me again. Because they don't realize, oh, you should go to the pharmacy and get your refill. You don't have to, your doctor doesn't have to give it to you at every visit. So I have a lot that about this controller just because they didn't realize it was something that they were doing forever. Anyway.
Yeah, I think we often fall in this rut of expecting our parents and our and our patients to make perfect decisions. And then we're disappointed when they don't. And we get really good at convincing ourselves that we make perfect decisions when we don't, but we're just really good at ignoring the times that we don't. But we don't build, kind of a community in the system that accounts for that, and make sure that those decisions, work well, regardless of whether we make them the right way every time. Yeah.
Maybe you covered this, but maybe I'm just not aware. When that case manager from the ED refers people to these programs, is there a communication back if they have a PCP?
Oh, so when they're being, so when we actually send them, do we let the primary care doctor know that they're being we haven't put that into our system yet, though. That's a great idea.
Well, and it would really help us being a care manager in a PCP's office that I know that you've already done this work, and that I can, what really helps me is that I can follow up on it and see if things are actually happening.
Yep.
And that's been really, really helpful in, I'll give the example of comprehensive care. They have it all cleanly spelled out in how to, and boy, I'll tell you that's my guidepost of what I need to do to follow up with them. And so that really helps immensely. Also, are the case managers contacting the insurance companies if, you select health as a primary, are they going back to the case managers and letting them know?
So no, right now they're not. We do have because we know that there are case managers in Select Health that are really enthusiastic about this and will help you. But I don't know what what that's like in other insurance products. And so, we're kind of, some of those things start to get really customized as far as so details we need to sort out.
Great question.
I know you've got to hurry along. And I hear from all over that the one complaint that I hear from them is that they don't even know when their kid was admitted or an ED. So I know that we have an automatic letter that goes out, but where does it go? And so it's a problem as far as that.
Yeah. It's part of it follows the billing, probably, right? Or
usually get it likely later after they've been I guess we're lucky in ourselves.
Oh, I see a plug in work right there.
And our patients call it easy to get. I think part of that has to do with clear stuff and so it's also a PCP problem. That's what I was great.
will we still be using fax machines in 20 years? Maybe. Maybe we can move on to the future.
Great. Thank you, Dr. Johnson. That was a great talk. And so I would like to go to Betty Sue, because school nurses, and all you.
Thank you. Thank you. So students with asthma and other conditions spend about 6 hours a day in school, and so we need, as parents and as school nurses, we need to know what to do with those kids to better manage their conditions, whether it be asthma or anaphylaxis or anything. So this is some of the data that we collected, and I apologize, oh, we're going to show it better than it says on the computer. So the data part of the data we collected was we had nurses across the state in districts, not necessarily in charter schools, we don't get good response from them, but about 21,000 students with asthma parent reported. Now, National Association of School Nurses is looking for only those diagnosed that are documented by a healthcare provider, so we asked the question twice. So how many are parent identified and how many have been identified by a healthcare provider? And that was determined by, do they have a healthcare plan on site, do they have medication order at school? So there's quite a number difference between those two. Out of the ones that were healthcare provider documented, we had about 7,600 students that did have a asthma action plan or an individualized healthcare plan or an emergency action plan at school. So if we're looking at those that are documented by a healthcare provider, that's pretty good.
That's really good.
we would like it to be closer to the 20,000 mark if that's really the number of students that have asthma out there. And we know that that number really doesn't mean anything because it's just what the school nurses are reporting. And they don't always hear from the parents that my child has a condition. Out of those kids, there were about 7,900 that had inhalers at school. So really there should have been more of those kids that had an asthma action plan at school. If they've got an order for an inhaler at school, there should be a healthcare plan at school too. And just for your information, there are 192 school nurse bodies, so people that work with school nurses in Utah districts, and a lot of them are part-time. So we don't have a lot of school nurses in the state. You're probably aware of that. But so we wish that we had one school that we were managing. It'd be a lot easier for them to help manage these conditions that are kids have, but that's not going to happen. So this is our asthma action plan, and it was created by a group, and I don't know, Kelly, if you were involved in this, but if you want to just pass it around. I've modified it just a little bit. This one here is what was created some time ago, and this is what most of the school nurses have been using. Now, when I talk about healthcare plan and asthma action plan, I'm relating it to school attendance. So they may have another action plan that they need to be worried about during the summer and on weekends and at home, but the school nurses are mostly just concerned with what's going to happen from 8 to 2:30 or whatever time the student is there. We modified it just a little bit because we're starting to create uniform healthcare plans for our kids at school, seizure, diabetes, anaphylaxis. We wanted them to all be a little bit more uniform. And so if you can see the one that's being cut up a little bit, but the information is the same. I just wanted to assure those people that worked on that committee, and I don't know how many of you may have worked on that committee. I didn't want to change the content, but I kind of changed the format a little bit. So this is the one that will probably be introduced to the school nurses. We have a conference next week, and I'll be introducing it to them, along with some of the other healthcare plans we've been working on for anaphylaxis and diabetes and things like that. So I want to assure people that if you're familiar with this form, that form's still okay. We're still using the same information that's on that. We're just reformatting it a little bit so it's a little bit more consistent. We also have it in Spanish. This is the only one that we've had translated into Spanish so far. So we're working on getting the other ones done, but that's available too. We have the section that the physician completes, the bottom portion here, and then the second page of the parent complete and the school nurse, so that we know where the inhaler is the student carrying it? Do they know how to use it? Is it in the backpack? Is it in a drawer somewhere? So, you know, medication, rescue medication isn't going to do any good if you don't know where it is. And so we want to make sure that everybody involved has that information. All these forms, once they're updated, will be available on the EPIC, which is the Department of the Utah Department of Health that I work for. So it's choosehealth.utah.gov. And then if you go to the pre-K through 12, it'll bring up a school nurse page, and there will be forms. We're working on updating that website. So the forms will be available to anybody who wants to access those forms. Unfortunately, they're not going to be forms that can be like an electronic health record that would be updatable and online available, so that, you know, if they went to the ER, they could pull up the information that's already been put on there. It's just a document that you can download. But it'll be available for this and also diabetes, anaphylaxis, seizures, and things like that we've been working on. This is my contact information. I only was planning on 5 to 10 minutes anyway. So I don't have a lot more to say there yet. I may be behind the scenes on here. Update on whether or not they are required. There is a state law that a student can carry their inhaler, but they have to have the documentation. So we have to have a medication authorization, which this is. So this one used to be, when the law was first passed, there was a state form that they needed to have along with the healthcare plan, or the district may also require medication authorization. So sometimes there were 3 forms. And then this, when it was created by maybe some of you in this room, I'm not sure, but when this was created, it included all the forms, with the exception of those specific districts that require their own district medication authorization. So the law, parents will come in and say, but my student can carry this inhaler, it's the law, but they didn't read the whole law where it says you have to have prescriber authorization and the parent has to sign the form. Once those forms are in place, which is this one form in most cases, then they can carry the inhaler. If they are knowledgeable enough on how to use the inhaler themselves. If they're not, if they're little kids, if they're special ed or whatever, then there'll be somebody at the school that will be trained to assist them when they need the inhaler.
Do they get this?
No. Yeah, as far as I know, it'll just, and there's always little tweaks that we want to make, you know, because we forget. On one form, we forgot a day, a place for day. So little things like that that are necessary that we forget. So as we come across things that we've missed, and feel free if you notice something, let me know, and we'll figure out how to put it in so that it addresses all those, but doesn't turn into a 20-page form. And yes.
Another question. So I do a lot of medication, and like Jordan School District and like the other school districts still have their own form online, and the only one I've seen that's accepted one is Park City. Is all of them going to accept this one for this?
Yes. Well, they will accept this, but like I said, if their district policy says that they have to have their own district medication form, that's a district by district or a charter school by charter school. This meets the law, the state law, the asthma law. Yes.
This is a lot better than their schools anyway.
Yeah, and some districts are just really nitpicky about getting all their T's crossed and I's dotted. But I know I came from Alpine District, so and they would take anything that had anything close to everything you needed. So, you know, pick your battles.
Where are they housed in the school? In the patient, student's folder, or?
No, they should be. It depends. It depends on the school. Now, when I was a practicing school nurse, I would have just a binder or a file with each student with a health condition's name on it, and the health care plan, the medication authorization, all that would be housed in it. And I would give a copy to the office staff since I covered 6 schools. I wasn't there all the time, so that my assistants could access that information. If they needed, there be a drawer with folders in it for each student's medication, along with the paperwork that applies to that particular student. Or the teacher would keep it, or if they carried it, then I would let the staff send an email out saying so-and-so has asthma, they have authorization to carry their inhaler to use if needed. Or if you need any instructions on how to assist them. Usually if they carry it, they know how to use it. And that's something that the school nurse would determine at the end of the year. Make sure they know how to use it if they're carrying it.
So if we work with practices and with providers and we voice some frustrations working with schools regarding that, can we get in contact with you?
Absolutely,
Okay.
yeah. And on any health condition. So we're I'm the liaison at the state for all the school nurses in the state, that small number of 192 school nurses in the state. I'm the one that I've got all their email addresses, I know who they are.
So how does the future look for school nurses? Do you think there's any? Yeah.
There's always legislation, and you may have seen a lot of news reports lately, and that's because of that annual report that I was talking about. The health department did a press release, so
I read it in NPR that
yeah.
children underfunded. Yeah.
So there was a lot of publicity right then, and I know we're talking to some legislators about possibly introducing some legislation, but that particularly goes nowhere. Yes, sir.
So we're part of the National Research Network for ER, and there's a proposal to do a study of kids getting their controller medication. Maybe they find a school nurse.
We thought it won't work.
That's what I was wondering. And as I thought about this, all the agreements that we in place with challenges. So are there any schools where they're big school nurses have their own school?
Park City. Park City, and that's due to some lawsuits that they had.
What about charter schools? Do they have charter schools?
I know, well, there's about over 100 charter schools, and I get reports of about 15 of those. The rest of them don't have schools.
And what about private schools?
And I only know 1 or 2 of those.
So
I do have nurses.
Are you? They're still.
Yeah,
they still report to you.
Well, I hate, I don't want it to sound like I'm their boss and they report to me, but I collect the data. I'm the one that they come to if they need questions, or if they have questions that need answers on any, I help interpret the laws and things like that. So I'm their resource at the state level. Yes.
I'm sure the answer is no. I just was just wondering if there ever been talks in some way, because there's never been talks that insurance companies or ACOs getting together and helping buy or pay for nursing school.
I don't know, and I would love, I was at a meeting yesterday where they were talking about Medicaid paying for school, for breakfast for kids that needed it. Well, a lot of other states will bill Medicaid for school nursing services. Utah doesn't. And I think that's a big missing piece of the puzzle right there. And our community partners would be a great idea. We just haven't, there hasn't been, to my knowledge, much discussion on that. Could be done, and I think it's a great idea. Anything else?
Thank you. Great. Thank you very much. Great information. It's finally great to make connections with school nurses because the past year tried and they're not very. So I'm very happy. All right. Well, it's 10 o'clock. It's end of our meeting. I think it was great. Thank you so much for all the information we have received. And the next meeting will be November 16th. Again, here at the Parent Center. And please stick around, grab some food, do some networking, talk. Oh, and parking validation. They have the sticker, so you can actually leave the parking lot.